Good evening, everyone, and welcome to the Canadian Concussion Center's webinar series, which is sponsored by the Laborers International Union of North America. My name is Leslie Rattan, and I'm very pleased to be moderating our 25 session webinar series that was developed for individuals that have suffered concussion, their caregivers, and their healthcare providers. And the sessions are going to be recurring every other Tuesday evening from 6 to 7 p.m. Eastern Standard Time. And just so you know, the sessions will be recorded and then subsequently available on the Canadian Concussion Center's website. So if you miss one, or if you missed our first one that ran 2 weeks ago with Dr. Charles Tatter, you will be able to go to the website and view that. Each session is going to focus on various aspects of concussion and include an expert speaker presentation for the first half of the session, followed by a question and answer period for the duration. And we would ask that when you have a question, if you have a question, that you enter it into the Q&A section as opposed to the chat section. And you should see the Q&A icon on the bottom right-hand side of your screen in the Zoom webinar application. And once you press that, a window will open and you can type in your question. On the flip side, if you have any technical questions, please do answer those into the chat section and someone can help you there. So for this evening's session, I'm really pleased to introduce Dr. Carmela Tartaglia. And Dr. Tartaglia is an associate professor at the University of Toronto and cognitive behavioral neurologist at the UHN Memory Clinic, where she sees patients with neurodegenerative diseases and persistent symptoms of concussion. She's a scientist at the CET.S Center for Research in Neurodegenerative Diseases, where she uses a multimodal approach for biomarker discovery to facilitate early detection of neurodegenerative diseases and diagnosis of persistent symptoms of concussion. The ultimate goal of her research programs is to develop biomarkers for early detection of disease so as to provide targeted, personalized treatments to her patients. She also holds the Marion and Gerald Soloway Chair in Brain Injury and Concussion Research. And with that, I'm going to turn it over to Dr. Tartaglia.
Hi, thank you very much. So I'm going to share my screen. Okay, so, all right. So we'll talk about concussion, which, you know, I think in many ways is an invisible brain injury with consequences. Oops. These are my disclosures. So the types of brain injuries, concussion, also known as mild traumatic brain injury, although they're often used interchangeably, they aren't actually equal. And the criteria for making this diagnosis was originally based on this Glasgow Coma Scale, which basically said, you know, tries to define how unconscious you are post-injury, and maybe not applicable to most people who have concussion. But let's say a person does have loss of consciousness. We expect it to be less than 30 minutes. There's sometimes a post-traumatic amnesia, so people not remembering the events, usually less than 24 hours. And so there can be impaired mental status at the time of the accident with some confusion, disorientation, and it's quite transient, which is very different from moderate to severe traumatic brain injury, where you actually see changes in the brain, such as bleeding, you can see tearing, bruising, or contusions. So a concussion is really an acute brain injury that's the result of an effect of a blunt impact or a mechanical energy that's applied to the head or another part of the body, which results in acceleration, deceleration, or rotational forces. So importantly, the trauma does not have to be directly to the head. It can be from a whiplash injury or a trauma elsewhere in the body. And usually there's an immediate and a temporary alteration of the mental functioning due to the trauma. This is a very common problem. It's a growing epidemic, really, in sports, in the military, in falls, from abuse, motor vehicle accidents. So the incidence of concussion is actually very high, and probably underestimated, because most people who get a concussion, or at least a very mild concussion, would probably never get medical care. So the estimates are about 750,000 concussions per year in North America, which is likely an underestimate because a recent study showed that we had about 150,000 concussions in Ontario per year. And again, these numbers only come because these people have had some interaction with the medical system. So it's often very underreported. The concussion diagnosis is a very difficult one. This is a clinical diagnosis. So basically, you have an injury and then you have symptoms. There are no diagnostic tests. There's a lot of, in the media, sometimes you hear about all these tests that could possibly detect concussion. Most of them are only useful if you have something more severe than a concussion. So they are not useful for concussion. The other issue is that concussed patients are a heterogeneous population, and we say that no two people suffer the same after a head injury. We can do some imaging, but usually actually, if you're strict about the criteria, the imaging should not show any abnormalities. The issue is that until recently, most people only got a CT scan. And so the criteria were really based on CT scans, and those don't show abnormalities. But MRI, which is more sensitive, can sometimes show change, like, minor bleeding in the brain. In terms of the symptoms, as you can see here, they're very varied. They're, usually fall into three domains: cognitive symptoms that include slowed processing, difficulty with the remembering, can't concentrate. There could be changes in personality or mood. So irritability is common, depression, anxiety, more emotional, change in sleep. And then physical symptoms, so headache, tinnitus, fuzzy or blurred vision, dizziness, sensitivity to light or noise, nausea, balance problems, fatigue. Any constellation of these symptoms can happen after concussion. And usually, luckily, most people recover. Okay, this concussion usually results in complete recovery in about 85 to 90%. Usually takes about 2 weeks in adults, 4 weeks in children. Neuropsych function is usually back to normal within 5 days. And it's a very diffuse injury. So we don't see any focal neurological deficits like from the cranial nerves or motor or sensory parts of the brain. In terms of prolonged persisting symptoms, usually about 10%, although different studies have reported different prevalence, but about 10% of people do not recover from the mild traumatic brain injury, and that's within the 3 months, which was the original description of persistent symptoms of concussion. More recently, it's been shown that it's about 15% that can experience prolonged symptoms, and that usually equals about 23,000 Ontarians per year that endure prolonged symptoms. And what are these persisting symptoms of concussion? It's a failure of normal clinical recovery. And that is the symptoms persist beyond the expected time frames. And as I mentioned, over 2 weeks in adults, over 4 weeks in children, although some guidelines suggest 3 months. They don't presume an underlying cause, and you really focus on the symptoms regardless of the cause. And these persistent symptoms of concussion really overlap many that you see at the time of concussion, although sometimes early on, a person doesn't have, very much cognitive deficit. And then, a few days in, they start to notice that they can't concentrate. They have more trouble with problem solving, or their speech is changed. It can take a few days or weeks to develop irritability and anxiety. So these are all, they largely overlap what you see at the time of the concussion, but sometimes they can develop a little bit later. What about neuropsychiatric symptoms? These are very common after concussion. So headache is the most common. It's upwards of 90%, and neuropsychiatric symptoms are close second. And I mentioned this because for some reason, people often overlook these symptoms. They, don't really think of brain injury, like a mild traumatic brain injury or concussion can cause this, but we see this quite often. Depression, 14 to 61%, anxiety also about 60%. More concussion seems to be put you at higher risk of these neuropsychiatric symptoms. And obviously you can have more than one. And they can overlap, with post-traumatic stress disorder, which actually is not uncommon after concussion, especially when people have concussion from motor vehicle accidents or from trauma. And they can obviously worsen a premorbid psychiatric condition. So what are some of the risk factors for persisting symptoms? There's a growing literature on this, no definitive answers yet, but it seems like history of prior concussion is one of the most uh, important symptoms for persistent, important factors for persisting symptoms. So the more concussions you have, the more likely they're persisting. Age, younger age, slower concussion recovery. There's also some evidence that maybe at older ages also, women seem to be at higher risk of concussion as well as for persistent symptoms. And mood disorders. There's some evidence that previous anxiety and depression can predispose to persistent symptoms. Previous headache, also one of the risk factors. And so in the Ontario Neurotrauma Foundation guidelines, there's these medical factors that are thought to predispose to persisting symptoms, and they span, different, physical or um, confounding factors, previous exposure to pain, pain medications, anxiety. So there's a number of medical factors that have been proposed as risk factors for persisting symptoms. Contextual factors, so injury sustained in a motor vehicle accident, there's not being able to return to work, being a student, having lots of life stressors. These are all factors that people take into consideration when we're assessing people, and mostly because these factors could predispose somebody to persisting symptoms, and we would like to be able to intervene earlier on. So prolonged symptoms are often non-specific, and the factors other than concussion can lead to concussion-like symptoms. And so these factors could be related to the initial concussive event, but they could also predate or follow it. They pose a diagnostic challenge because, like I said, concussion is a clinical diagnosis, as is persistent symptoms of concussion. And there are symptoms that are secondary to concussion, such as the psychological sequelae, pain, injuries, and these will all influence the outcomes. Medication side effects also can lead to concussion-like symptoms. And so when we think of, a concussion, we think of it's happening to a brain that, subserves many different functions. And so, it's almost like you can think of the brain as all these gears that work together. But if the gears stop, you end up with all these symptoms. And so we really try to intervene to get these gears working better, because we feel that if you can get one of them going better, it'll entrain the other ones. And so if you improve somebody's mood, you can improve their cognitive function, because we know that poor mood affects memory and concentration. If you improve somebody's headache, you likely will improve their mood as well as their cognitive function. So we try to intervene where we can. So in terms of treatment, we treat all the symptoms. We don't have concussion, depression treatments. We have treatments that we use for mood, and we'll use the same one. So antidepressants, if somebody's suffering from anxiety or depression, cognitive behavioral therapy has a lot of evidence. We treat headache. We use the same medications that we use in primary headache disorders, but we try to give medications to prevent headaches. Sleep apnea, common problem after concussion, and so we treat that. Vestibular physiotherapy if you have balance problems. Low impact exercise for everybody, because we know that helps people recover. And modified return to work plans, or return to school or play, because also this has been shown to be beneficial. We treat the neuropsychiatric symptoms. Like I said, we prescribe exercise for everybody because there's evidence that exercise is good for neuropsychiatric symptoms, for sleep. And like I said, it's evidence in post-concussion syndrome or persistent symptoms of concussion. Another more recent concern is for the delayed effects of concussion. And I think in the moderate or severe traumatic brain injury, there was quite a bit of evidence that patients were at higher risk of a neurodegenerative disease later on in life, which kinds of makes sense because that's a pretty significant injury that sets up some process in the brain. But I think what was of interest was, what about, single concussions or multiple concussions? I think in the recent years, people have been quite concerned about, the impact of multiple concussions, especially on the risk of late life dementia. And these studies that, really looked at large databases do find that there is an increased risk, mostly with repeated concussions. And one thing to note is these studies are made at a population level. So in terms of, really being able to exclude anybody with a little bit of blood in the brain is very difficult. A lot of these people did not get imaging. A study of 178,000 veterans is usually a study with no brain imaging, everybody just getting a clinical diagnosis. So obviously there are caveats to this, but I think we can safely say that we think especially repeated concussions is bad for the brain, and that we really want to avoid activities that put us at high risk of especially repeated concussions. There was some evidence that even a single mild traumatic brain injury does increase the risk, but how much of this is really unknown. And these studies were done in people in late life, and I can tell you that since there's an increased risk of concussion, I have patients who come in with classic Alzheimer's disease, and they can remember that when they were 3 years old, they fell while playing with their friend. So, the devil is going to be in the details here, and obviously repeated concussions, I think, are a risk factor, but one single concussion in your life, I'm not sure, because I think most of us as children have hopefully played, and probably taken a fall or two. So it has, head injury has made it to the 12 dementia risk factor. I guess in July 2020, there was a commission that was put together, and basically to outline the 12. These are supposedly preventable, modifiable risk factors that are associated with dementia. I think when you look at this list, you can see that there are many factors there that are easy to intervene on and are very common, and are associated with late life dementia. So it's very difficult to parse out the contribution of head injury versus air pollution versus infrequent social contact, obesity. So there's many factors here, but I think as much as we can do in our lives to try to really promote brain health, and that means that if you can avoid an activity that puts your head at risk of a concussion, then probably you should. I realize that it is difficult to do, just like trying to avoid air pollution is quite difficult, although avoiding physical inactivity shouldn't be that difficult for us. The entity that actually has put traumatic brain injury on the map, or on in everybody's I guess day-to-day life, is this entity of chronic traumatic encephalopathy. This is a progressive neurodegenerative process that seems to be triggered by repetitive mild traumatic brain injury, including concussive and concussive blows. And it evolves slowly over decades, and it seems the symptoms really appear years after injury. It was actually first described in boxers, and that's in the 20s. But now it's been observed in hockey players, football players, and other sports, but as well in the military, motor vehicle accidents, and abuse. The symptoms of chronic traumatic encephalopathy, which in some ways are quite similar to what we used to call dementia pugilistica, which was the dementia of boxers, are very similar in some ways to what we see in concussion. So lots of symptoms, lots of behavioral psychiatric symptoms, some cognitive, What we see in dementia pugilistica, there's a lot more motor problems in chronic traumatic encephalopathy. So what these football players are getting and hockey players, actually we see almost no motor problems. So what we're seeing in terms of chronic traumatic encephalopathy does seem to be more of a behavioral cognitive disorder. And, I think the challenge is that right now we cannot make these diagnoses in vivo. I see people in my clinic who, played some sports when they were younger, and probably maybe have suffered from repeated concussions, and now in their 50s and 60s and complaining of memory loss and some changes in their personality. And these symptoms overlap in all kinds of conditions, right? And the symptoms of concussion overlap persistent symptoms of concussion, and some overlap chronic traumatic encephalopathy, which also overlap all the neurodegenerative diseases. So, we're working really hard to try to find what we call biomarkers. So, a test to be able to tell somebody, yes, you've had a concussion. Yes, you still have persistent symptoms of concussion, or a state that reflects these persistent symptoms of concussion. And, yes, you have chronic traumatic encephalopathy. But right now we cannot do that. In fact, the only condition on this slide that we can detect with any certainty is Alzheimer's disease. Everything else is clinical judgment. And so to summarize, concussions are the result of a brain trauma or brain injury. The symptoms are very, very varied. They include memory problems, headache, dizziness, sleep issues, psychiatric symptoms, in some cases, motor problems. And persisting symptoms can occur, and they're actually not that infrequent. When you think of the number of people suffering from concussions, even if it's 10%, that's a lot of people. There are certain risk factors for concussion, for persisting symptoms, and I think the importance of that is because I think as a society, we would like to be able to flag the people who need more intervention earlier on. Many people recover on their own. And in those people, we really don't necessarily want to intervene, nor can we afford to intervene. But if somebody has risk factors for persisting symptoms, I think that's where, the biggest bang for our buck. We would like to be able to start interventions early on, so as to avoid the persisting symptoms. And, there are many symptoms that have treatment. We are quite good at treating headaches. We are quite good at treating psychiatric disease. And so, I think it's really important for us to treat the symptoms while we look for a cure for the brain problem. But in helping some of the symptoms, oftentimes my patients do get better and they go back to their lives. So thank you. And I guess I'll stop sharing and take your questions if anybody has any.
Great. Thanks so much, Dr. Tartaglia. Yes, we already have a few questions. I think I'm going to start with this one. We actually have someone from the Yukon and who said that they'd love to see a best practices or guidelines developed for concussions. They suffered a concussion almost 6 years ago and had very little care. And it was really just through their own research and talking to other people with concussion that they had figured out different ways to deal with it. And they also note that they're still having some vestibular issues today. So just wondering if you can comment on that.
Yeah, that's a great question. And, I think we're very fortunate in Ontario. We do actually have the Ontario Neurotrauma Foundations, and you can go to their website and actually download, patient version of these guidelines. And so these guidelines were developed with experts in many fields that take care of patients who've had concussions and persisting symptoms, and really trying to guide the healthcare practitioners on how to best deal with these symptoms. As you see, there's many different symptoms, and so if people are unaware of how to intervene, oftentimes our patients are left kind of struggling and not able to navigate the system very well. And these guidelines, I think, really help with that. And there are some for the physicians also.
Great, thank you. I think I'm going to combine, there's a few questions here just in terms of, and this is a common question, just in terms of when symptoms appear. So someone was asking, can they appear 7 to 14 days after you're injured? How long after the injury can new concussions symptoms appear? And then someone else asked, can vertigo show up a year after you've had the concussion?
Yeah. So I think most of us would like to see the symptoms appear within 7 days. I think, the fact is that sometimes, when you don't get better after a month or two, you can develop more, depression, anxiety, those kinds of things. But within the first 7 days, we would like to see a lot of the physical symptoms. So, and the person who asked if a year later I can, you can develop vertigo as a consequence of a concussion, I would say that's highly unlikely because, vertigo usually comes about because of an inner ear problem. So it doesn't really make physiological sense to me that the vertigo would come about a year later. You would expect that it would come about within that day, within a few days, and then hopefully over the year resolve as the brain adapts. But there are many other causes of vertigo outside of concussion. And so I would look into those.
Great, thank you. And then we've got a couple of questions as well around vision problems. So someone indicated they'd experienced many vision problems throughout their concussion, including converging and tracking issues. They've chosen the route to take vision therapy, but are aware that research shows conflicting results. Want you to sort of update us, if possible, where the research is on vision therapy and the use of prism glasses. Yeah.
So vision therapy, there's actually a few good reviews that have come out in the last few months. And basically, the end result or the conclusion is that there is very little evidence for vision therapy in concussion. There's evidence for vision therapy in children who have strabismus. So there's, some congenital problems. And what's happened is that therapy has been extrapolated to patients who have concussion, who've had a concussion, but the problems that you see in these children aren't detected in the adults after a concussion. And so it actually doesn't make that much sense to use the vision therapy. I think, we all keep an open mind. We would like to see more research in this. I'd say lots of my patients have vision issues. I send many of them to neuro-ophthalmology, and I have a few where they've had more significant injuries and we actually find a problem. And that's different, right? Because in that case, we find a problem, it can be addressed. Most patients, though, the neuro-ophthalmologists do not find any detectable vision issue. So prisms are useful if you find a problem, right? Because they help the eyes converge. So you can use these prisms to try to bring things online. I see patients with other diseases and they have convergence problems. They have lots of double vision. So we use prisms all the time. But in concussion, the evidence isn't actually there for most people. Now, if they find a problem, I would say, and it's amenable to prisms, then for sure. Yeah.
Great, thank you. Concussions don't show on CT scans in the acute phase, but can they over time show accelerated brain atrophy?
So we do, in my research program, we look at people who've had multiple concussions. So these are former contact sports athletes who've had, their sport basically, required them to basically hit their heads almost every day. And so at a group level, we do see that there seems to be accelerated atrophy. You have to know that as of the age of 30, your brain starts to shrink, and it shrinks a little bit every year. And that's normal. It looks like people who've had, as a group, people who've had a concussion, their brains have accelerated atrophy in certain parts of their brain. So not the whole brain, but certain parts. That is different than saying at the individual level. Like what we want is a test that tells you if you have a problem. There's no use if we put you in a group and say, yeah, at the group level. So do we think that multiple concussions are harmful to the brain? I think so. I think we do. Do I think that some people are more vulnerable to this than others? Yes. There's probably a genetic makeup that makes even the result of one concussion different, because each of us has probably hit our heads many times, and many times it didn't result in a concussion. And 10 people will hit their heads and 8 of them will walk away, not even realize. One will have concussion symptoms, and those will last for a few weeks, maybe a month. And one person can have very prolonged symptoms. And a lot of that is actually based on our genetic makeup. We just don't understand. And that's the same thing for anything, right? Not everybody gets the flu, even though we're all exposed. Not everybody gets cancer, even though we can lead similar lifestyles. So there's something about some people's brains that makes them vulnerable. And those people, if they're subjected to multiple concussions, probably can end up with accelerated aging.
Great, thank you. Here's another one. Are there any supplements or dietary changes that can aid in recovery?
So I think, when people have concussions, we always promote brain health. So we promote what is known to be beneficial to the brain, and that is diets that are low in fat, high in vegetables, fruits. So you want to keep yourself healthy and thus your brain healthy. There is no evidence for any supplements, for any minerals, for any vitamins, unless you have a vitamin deficiency. That's different. So unfortunately, there is nothing that, other than having a healthy diet that will speed up recovery. That is different than exercise. There is a lot of evidence that physical activity, low impact aerobic exercise is really good for the brain. That is so even in concussion now, it's definitely good for preventing neurodegeneration. So, if somebody's worried about delayed effects of concussion, it would behoove you to even be more adamant about practicing physical activity.
Great. Here's one. I'm 1 year in, have almost every risk factor that you mentioned. What are the early interventions you would recommend?
So I have an approach where I, basically would outline every symptom that you have, and then depending on that, use a staggered approach to try to intervene. So let's say you're 1 year in and you still have headaches. Okay. Headaches are a huge problem, right? Because you can think of how distracting they are. So if you have 1 year and you're at 1 year and you still have headaches, we would say, let's try to treat the headaches. The way we treat headaches is get everybody to stop their Tylenol, their Advil, all those medications that give people headaches. And then we would put them on a headache prophylaxis. So you take something that will prevent headaches. Then let's say, so that's for the headache. At 1 year, a lot of times people will have a lot of mood issues. So let's say they have anxiety, depression as a consequence of their concussion, we would address that. Usually we address that. If it's at 1 year, I would say it's probably time to start a pharmacological intervention, along with some cognitive behavioral therapy, psychotherapy. I think the dual approach is best for that. Another thing is sleep. Sleep often changes after concussion. So we send people for sleep studies because you can see these sleep abnormalities. Actually, obstructive sleep apnea is not that uncommon after concussion. So, and that has a treatment. So really, we identify all the symptoms that are preventing a person from getting back to their work or to their life, and try to address each one. If they have vertigo, we'll do some vestibular physiotherapy. If they have, neck pains, we can send them to physiatry to try to address that. So really working on each symptom individually, in addition to, brain health. So exercise, ongoing learning, being exposed. We don't want people in dark rooms. We want people to be using their brains little by little, so that they can get back to their regular activities.
Great, thank you. Just on the headache issue, someone's asked, when is a good time to go off my migraine medication in the recovery? When the headaches are getting better or when waiting until they're completely gone?
Yeah, I usually tell my patients to wait till they're gone, tolerable, right? If you're getting one headache a month, well, a lot of people will say, I can tolerate one headache a month, two a month. I mean, and then I would say, stay, like, let's say your headaches get to two a month and you think that's perfectly fine, I can live my life. Then I would say, stay on the medication for a month or two, and then you wean yourself off.
Okay, great.
And you should talk to your doctor, obviously, about that. Make sure that you're not taking that medication for something else also. Like we use blood pressure medication sometimes, but if that medication is also used for your blood pressure, you don't want to come off of it.
Great, thanks. Can you explain a back to work or return to work plan for someone that has concussion and vertigo?
So it really depends on, what's bringing on the vertigo. So the first thing would be to, we would send people to ear, nose, throat doctor to get that vertigo assessed. Is it true vertigo? Many times it isn't actually true vertigo. True vertigo has treatment. So I think that's the main issue, is to figure out, is it a vertigo that actually is amenable to vestibular physiotherapy? And, I would work on that. If it's not true vertigo, it's, some people feel dizzy, lightheaded, then we see, is it associated with headache, and try to work at that. And let's say, you're getting better, but you're not back to your baseline, you still have some symptoms. We can still go, move towards a graduated return to work, depending on what your work is, right? Like if you work on a construction site and at a high risk of falling and you got a little bit of a dizziness, probably not good. But maybe you have a desk job. And that way we'd say, okay, depending on how long you've been out, we would do a graduated return that includes things like, one, exposure to your environment, right? Just going into an environment that is like the place of your work, and maybe not even your work, but similar. And so being exposed to the lighting, to the sounds, to, having to pay attention to people. So when people are off work for a while and let's say they can't get back or right away, I usually say, go volunteer at your library. Do something where you have a structured, you have to be there for a certain amount of time, you have structured activities, you're exposed to other people, and for small amounts of time, right? So you would start initially with maybe an hour every other day, 2 hours every other day, depending, and then slowly build up to that. It obviously depends on what your work is. A teacher, I had one teacher this week where I said, okay, you're going to go back to class. She has been out for almost 2 years. Go back to class, sit in the classroom, don't teach the class. Just sit there for, maybe an hour or two every other day for a week or two, and just re-expose yourself. Because you have to think about it like, if you're, let's say, in bed for a few weeks even, but let's say even for, let's say for a year, when you get up to go to the bathroom, you're going to be sore. You're going to be unable to move very well. And it will take you some time to rebuild your muscles, to rebuild, your stamina. Well, you have to think your brain is like that too, right? So we need to re-expose it to the kinds of stimulation that we're exposed to our whole lives and we're fine with.
Great, thank you. And I just see a comment or question actually in the chat. How often do you refer clients to occupational therapists for concussion recovery, as they can help support physical, cognitive, emotional functioning, as well as help with return to work, that kind of thing?
Yeah. So I refer many patients if they have coverage. Unfortunately, occupational therapy is not covered by OHIP, and so and the patients can't afford it. But patients who have coverage because they've had a motor vehicle accident, or it's a work-related WSIB, or they have their own plans, then I send many people many people to occupational therapy, because they can be very, very helpful. And sometimes just giving people like simple strategies reduces their anxiety so much that they do exponentially better just because they have those strategies.
Yeah, great. Thanks. Just switching gears a little bit more from the neuropsychiatric side, is PTSD caused by brain injury or does PTSD cause the MTBI?
No, so I don't think so. You can have PTSD and never have had a concussion. Actually, more often than not, post-traumatic stress disorder does not happen in the context of concussion. But but a lot of the symptoms that you see in PTSD look very much like what you see in concussion. So people can be depressed, people can be irritable, can be, have these changes in personality that make them more explosive, can be anxious, not sleep well. So you can see how there's an overlap. And oftentimes, what I see when people have a concussion and PTSD is that the PTSD part is missed. So people will have a motor vehicle accident and they'll talk about all the concussion symptoms and, trying to get better. But, if you don't ask people the fact that they're having nightmares every night, which awakens them, that every time they get into a car, they start to have a bit of an anxiety panic attack. So it's important to address both, but they don't cause each other. A PTSD and a concussion can result from a motor vehicle accident. It's not like one causes the other. But if you don't address them both, I think you'll hinder the recovery.
Great, thank you. So there's a question around the reason why women indicates on one side you stated that it's more likely for women to suffer concussion, and they're asking, is this because women may be more likely to seek medical attention?
Yeah, and that's a great question. We actually don't know. I think in some cases people think that, but there's a lot of, I think there's increasing evidence that, the hormones might have a role in concussion, that there may be some, you know, um, there are differences in the way our neck muscles are developed. So, they've looked at this in sports, similar sports like soccer, men and women play. Women are more likely to get concussed, more likely to get suffer for more persistent symptoms. It's, it's unknown. Maybe there is an element where women will report more, but I think most of us in the field do not think that's the sole reason for this, quite a large difference between men and women's incidence of concussion.
Thank you. This is a question from a family physician who says they often have patients presenting to their office after an ER visit and persistent symptoms, and they're wanting to know, where does imaging play a role?
So, I think in the early stages, there's criteria for the emerge to order a CT scan. There's like these red flag features. So many times people aren't necessarily getting imaging if they don't, nobody feels they do. I see people with persistent symptoms, and I feel that if you still have symptoms at a few months out, I do get imaging. And I get an MRI. CT scan is not going to show me anything. I'd say in hundreds of MRIs, 99.9% are negative. And that's how you make the diagnosis of concussion, right? Like, in the sense of it contributes. So for the family physician, I think you're kind of in that intermediate, in that in-between stage where I think, it's really about clinical acumen. Because if your patient is, a week out and, complaining about, they have a headache, they have typical symptoms, they're having a bit of trouble sleeping, no focal neurological signs, they feel like maybe they're getting a little bit better, I'd say that's okay, not necessary to image. If they're at, a few months out and they're still complaining and they don't feel like they're getting better at all, I would send them for imaging.
Great. Have any of your patients benefited from alternative medicine, such as osteopathic interventions?
Yeah, so I think that, I mean, for me, alternative medicine is really all like physiotherapy is alternative. Anything that's non-pharmacological is alternative. So, I practice alternative medicine because I prescribe exercise to everybody. I think osteopath, just like anything else, if you have a problem that an osteopath can fix, that could be good. So if you have some, back problem from your accident, right? You have a motor vehicle accident, you can have a concussion, you can have back problems, you can have neck problems, and I think osteopaths can work with those areas. Uh, I think you have to think of these symptoms as, okay, what's the underlying cause? And if you had a brain problem, well, you probably wouldn't see an osteopath, because I don't think you would think the osteopath would be able to fix a tumor or of your brain, or multiple sclerosis in the brain. You would see a neurologist, you would see a physician who or physician that deals with the brain, or a general practitioner that makes sure you don't have any other medical problems and can also think about the brain. But you wouldn't go see your chiropractor, you shouldn't go see your osteopath for that. So I think you have to think of what is the symptom that they're actually targeting, and does it come from a system, like your back or your arm, or does it come from a system that they treat? And I think that's the important thing. If somebody had a heart problem, they should not come and see me. I do not want to see them, because although I was a medical student and a resident, and I did take care of people of heart problems, and in my neurological patients, I take care of heart problems, I'm not an expert in the heart. So if they have a primary heart problem, don't come see me. I don't diagnose heart problems. If my neurological patient has a heart problem, I will follow the guidance of their cardiologist, and I can do that, but that isn't my area. So I think you have to know what you're going and see that physician for. And I think I think like anything else, therapy is just like a medication. If you're given a medication to treat your blood pressure, you would give it a try, right? You would maybe try it for a month. And if it decreased your blood pressure, great. And if it didn't, you would go see your doctor and say, hey, this isn't working. Let's do something. And your doctor would hopefully increase, change, add, do something. Because the end goal is to fix the blood pressure. All therapy should be thought of in that way, because A, takes up your time, B, usually costs money. So what's the target, and are you getting there? And if you're not getting there, revisit, find a different therapist, reassess the need for that therapy. But time is valuable.
And actually, following up to this, there's a comment about asking you to comment on the relationship of neck issues and concussion.
Yeah, so neck issues are very, very important, right? Whiplash injury is very common in certain types of injuries, right? You think of motor vehicle accidents, many people can have whiplash injury. Actually, the whiplash injury can give them the concussion symptoms. So it's very important to address that. And so, if people have neck problems, they can give you headaches. And you might need an MRI of the neck, depending on what, the causes of your neck problems. Maybe you need to see a physiatrist. Maybe you need to see a physiotherapist, massage therapist. It's very common, and so needs to be addressed.
Right. Here's one. Do you have any plans to make family doctors educated about concussion and about referrals that they can make?
Yeah, so there's a great program that actually has been that is ongoing now, and will is hopefully recurrent. It's called ECHO, and it's basically trying to empower community physicians, allied health, people who are dealing with patients who have concussions. I mean, the family doctors and all the community helpers, they're first line. They're seeing them much more than I ever see, you know. So this ECHO program really is about expertise within, you know, the a lot of them are from University Health Network, but there's people from Ottawa, from the community, from, you know, all areas, and different types of allied health are in there. So there's physicians, there's occupational therapists, psychotherapists. Dr. Ratan is part of it also. And this program is really on a weekly basis for, I think, Leslie, 8 sessions or 10 sessions or.
Yeah, I think it's maybe even more than that. Yeah.
Yeah.
And it's
And
free. Yeah.
a weekly basis, there's a short didactic and cases brought from community. It could be physiotherapists, it's community interveners. I mean, it spans physiotherapists, chiropractors, osteopaths, whoever has a case that wants to discuss. And then everybody weighs in, you know, some of the experts, but as well, lots of people in the community have, already assessed people such as this. They have experience in this. I mean, there's people who are part of the community who have been seeing concussion patients for decades, and they have a wealth of expertise. And so people can share that expertise as part of this ECHO. So yes, that exists.
Yeah, that's great. So in someone that is 3 years out from their concussion, they're still having chronic fatigue and brain fog. Even with a great medical team supporting them, they're saying, you know, is there any hope or evidence that this is going to subside or improve?
Yeah, and it really depends on what the symptoms are, what symptoms have been targeted. It's hard to know. I mean, definitely, you know, the longer a person suffers from persistent symptoms, you know, we always remain optimistic that, you know, we can intervene and things can get better. But I think this is the issue about, you know, not focusing on the cause of a symptom, but trying to address the symptom. Because sometimes a concussion, you know, the brain injury of concussion will heal, but it triggers some symptoms that, you know, persist even without the initial event there. So one example is something called phantom limb pain, right? So you don't even have the limb anymore, and you still have pain in a foot that no longer exists. So that's the way our brains are. Sometimes something happens and then it sets up this cascade, and the cascade has a life of its own. And so it's important to address that. I think the importance of that is often underestimated. So, you know, I'll give you one example. I had a patient who came to me, and she was 10 years after a concussion. But I tell you that a lot of her symptoms actually had not been targeted. And so I guess after 10 years, she was more willing to accept some therapy. And anyways, after about 6-7 months, her headaches went away, her mood improved, her concentration was better. She came to a follow-up visit that usually I tell people, if you feel better, don't come, just cancel the visit. She came with her husband to tell me, well, he told me that I had given him his wife back, and she got a job which was so much better than the job that she had like 10 years ago. So I don't lose hope, because this woman, she hadn't had interventions, right? She had been actually herself very reluctant. She was really just hoping that over time things would get better, and then started to, you know, kind of spiral downwards, right? With more depression, and put on weight and became anxious, and her headaches got worse and developed sleep apnea. So there was just a lot of things. But when we targeted each one, she could improve and she could get back to her regular life. So I don't give up hope.
Great. Here's one about sleep. Should you sleep more often, less, or periodically when diagnosed with a concussion?
I think so. Concussion changes sleep. Okay, and it does have an effect very often. And so a lot of times people tell me, I have insomnia now. I didn't have it. Get up early. I wake up during the night. We want people to get good sleep. We don't want them to get more sleep. We don't want them to get less sleep. And we want them to get whatever amount of sleep, usually at least 6 hours though, that they used to get before. But we want to make sure that they get good sleep. So if they tell me that they can't fall asleep, well, we try to intervene. I often will make suggestions about different things that people can try. Sleep hygiene is hugely important. Mindfulness for insomnia has a lot of evidence. Cognitive behavioral therapy for insomnia, a lot of evidence. So I think it's really important to get good sleep. And that's not just for concussion and recovery, for many, many illnesses. But I don't think we want a person to change their sleep time unless it was very bad. Like if you were sleeping 3 hours a night, well, you should have gotten more before, and definitely we want you to get more after. But otherwise, you should just, aim to get back to what was satisfying before.
Great. Okay. I'm just conscious of the time. We have a lot of questions. I think we'll do one more question. This one is, what would you recommend for nausea or motion sensitivity?
Nausea or motion sensitivity. So the first thing I would recommend is that it be assessed in the sense of to rule out of an inner ear problem. Okay. And then I usually, in some cases, people will do kind of try to accommodate. It's very tough. The issue is that if it's for short periods of time, people can try things like a circ. So it's this little patch that you put behind the ear, and in some cases can work for motion sickness. I mean, people can have those kinds of feelings even without concussion, and so there are some treatments available. People have very significant motion sickness and they can sleep. We give them Gravol. Oftentimes I ask the ear, nose, throat person though to at least rule out an inner ear problem and make sure we're not missing that.
Great. Okay. I think we better call it there. Thank you so much, Dr. Tartaglia, for your presentation and for answering the questions. Just to all of you, thank you so much for participating. There were, unfortunately, a lot of questions that didn't get answered, but what I would say is take a look at the agenda in terms of our upcoming sessions, because each session is going to focus on specific symptoms. So for example, we'll have one on dizziness, vestibular issues, visual problems, fatigue, cognitive issues, and so forth. So you'll be able to get more information there. I had just seen a few, just to reiterate, so the Ontario Neurotrauma Foundation guidelines, if you could just Google Ontario Neurotrauma Foundation concussion guidelines, you will come up with that. And same with ECHO. I think if you were to Google ECHO concussion, University Health Network, you can find the registration information there. And also just a reminder, all of the sessions are being recorded and will be put on the Canadian Concussion Centre website so that you'll be able to access those. And then we're also going to be forwarding everyone that participated just a short survey. So if you have a minute or two to fill that out, we'd be really interested to get your feedback and suggestions. And finally, our next session will occur on Tuesday, March the 30th. That's in 2 weeks at 6 p.m. And that's going to feature Dr. David Michaelis, who's actually going to talk more in depth on the imaging of concussion. Thank you very much and have a good evening.